So I'm going to share a little bit about my work looking at parent-targeted postnatal educations in low and middle-income countries. And today I'm going to be talking primarily about two reviews that I led. One was a scoping review on parent-targeted interventions in low and middle-income countries. And then the other one is a systematic review looking specifically at health interventions. So just to give you a little bit of background, I'm sure most of you are familiar with this. I won't spend a ton of time on this. So we know that the postnatal period is particularly vulnerable for infants and mothers, with 2.4 million infants dying worldwide each year in the first month after birth. It's a critical challenge in low and middle income countries where most neonatal deaths occur. In the most recent United Nations report on child mortality, deaths within the first 28 days was at a rate of 17 out of 1,000 live births. And many of these newborn deaths occur at home, regardless if the mother gave birth at a health facility or had a skilled attendant at birth. In a recent systematic review that I'm leading on the timing of neonatal mortality, we found that 40% of infants die in the first day and 36 within the first week. Today's 1 to 3, so 76 within the first week total, which really does make the first week the most vulnerable time in the postpartum period. And we also looked at the causes of death within this period. So none of this is really surprising, but we can see that the birth asphyxia is the leading cause in prematurity on day 0 and decreasing thereafter, but prematurity kind of maintains throughout the full neonatal period. And then the blue is severe infection, which is very small on the first day, and then grows increasingly over the rest of the neonatal period. And so while interventions provided by healthcare providers in the hospital, such as newborn resuscitation, has been found to decrease newborn mortality in low and middle income countries, mothers and newborns continue to die after they leave the hospital. And despite the opportunity to engage mothers in reducing newborn death, mothers in low and middle income countries do not receive much postnatal support or consistent training before leaving the hospital to harness their full potential in optimal care. With high rates of maternal and neonatal mortality and morbidity rates, gaps remain in mothers' access to and use of perinatal services, as well as the knowledge and self-efficacy needed to provide ongoing care at home. And one of the opportunities that warrants further attention is the education of moms and dads with knowledge related to the provision of newborn care at home. And mothers are often one of the most underutilized resources in low and middle income countries. Parent-targeted postnatal education is defined as structured forms of education provided to parents and is thought to enhance parenting behaviors through the development of knowledge related to caregiving and increasing parents' skills, confidence, and competence in caring for their newborn. So family members are essential in the provision of ongoing care at home. In low and middle income countries, care provided by families has been found to reduce newborn mortality by 10 to 50% through things like hygienic umbilical cord care, support and promotion of breastfeeding, appropriate thermal care and kangaroo care, particularly for our preterm and low birth weight babies, as well as attendance at postnatal visits and receiving family planning advice. Challenges do remain, though, due to system level, hospital level, and individual level barriers. Only 63% of mothers and 48% of newborns have a postnatal visit within 2 days after birth. And in low and middle income countries, the use of postnatal care services remains highly unequitable and varies depending on socioeconomic status and geographic locations, whether they're rural or urban. So despite the potential positive impacts of parent-led behavior on newborn outcomes, there's been a limited synthesis of educational strategies and interventions targeting parents during the postnatal period and their impact on maternal and newborn outcomes. So the question is, given what we know about the power of parents, what is being done to provide parent-targeted postnatal education in low and middle income countries? So before I kind of get started on answering that question, I wanted to briefly describe the difference between a scoping review and a systematic review. So a scoping review are commonly used to better understand the phenomenon and explore the research on a topic that has or has not been completed to date, So it's considered iterative and reflexive based on emerging evidence. And this is in contrast to systematic reviews, which have a very clear question and outcomes and uses very specific steps to identify the research and collect and analyze it. So briefly, the scoping review is often questions are broad, whereas systematic review is very focused. One thing that is the same amongst both is that the search is very systematic and transparent in both. For scoping reviews, the inclusion criteria is flexible and it can change depending on what's emerging in the literature, whereas systematic reviews are very specific and defined ahead of time. There's no study appraisal in scoping reviews, but there is in systematic. And then the synthesis of the findings for scoping reviews is often qualitative and summative, while their systematic reviews is often quantitative. So the first paper that I'll be discussing is parent-targeted postnatal educational interventions in low and middle-income countries, which is the scoping review, and it is published in the International Journal of Nursing Studies if you are interested in learning more. So the objective of this review was to map the current evidence on parent-targeted postnatal educational interventions, looking at maternal psychosocial outcomes and newborn health outcomes. So the question, so we were interested in the participants were family caregivers. We included both mothers, fathers, grandparents, and any other family members providing care to low and middle income newborns in low and middle income countries. We were interested in parent-targeted postnatal education interventions related to improving newborn care. So we were very broad in terms of what they could be focusing on. And it had to occur at any point after birth before 6 weeks of age. We included any comparison group, and we were interested in a variety of outcomes. Again, we kept it quite broad. So any newborn outcomes such as exclusive breastfeeding, skin-to-skin contact, or mortality. And we were also interested in parental outcomes related to the actual provision of the educational intervention, so knowledge and self-efficacy, as well as parental well-being, such as anxiety and stress. So we ran the search and it was quite broad. We searched in October of 2017 for all studies published after 2000. We included all study types and we identified just over 9,000 studies. And after screening for both title and abstract and full text, we identified 77 studies that were included. So when we take a look at the studies that were included, what we can see here, these are the number of publications over time. So you can see that the first study was published in 2001, an increase thereafter, with the greatest amount of studies occurring in the latter year, so between 2014 and 2017. We also looked at where the studies were occurring, and we found that most studies were occurring in South Asia, so 21 studies, followed by Middle East and North Africa, and there was a variety of studies that were included, or countries that were included, sorry. And then in terms of participants, we found that all studies targeted moms, and 7 also included fathers. But no studies specifically just targeted fathers, and no studies targeted other family members. So it is very much a mother-focused educational programs that we were finding. The sample sizes in the studies range quite considerably, so range from 11 to over 16,000 with a median of 135. And in terms of the study type, most were quantitative. So 42 were randomized controlled trials, 28 were quasi-experimental using a comparison group, and 18 were pre-post. So it's quite varied in terms of how these interventions were being described. And then we also looked at the content. So we found that 61% focused on a single topic when they were doing their education. So most of that was breastfeeding, followed by kangaroo mother care. And one interesting thing we found was that low and middle income countries were more likely to focus on a single intervention topic compared to upper middle income countries, which were more evenly split between a single and multiple interventions. And then 39% focused on a multitude of topics in their intervention. Again, you can see most of that was breastfeeding, as well as a general or unspecified topic and infant needs. And then it kind of varied after that. And then the strategies for providing the postnatal education interventions to parents also varied across the studies, with most interventions using on average 3 different methods. So most included a verbal component followed by written material or counseling or support. And this was consistent across low and middle and upper middle income countries, with home visits more likely to occur in low income countries. We also looked at the number of times that there was an interaction with the parent, and most of these were only one interaction, so just over half, and then it kind of varied thereafter. And then in terms of when researchers were following up the participants, most of this again was at discharge, followed by 6 months at 17% and 2 months. So again, the follow-up period varies quite considerably. And then next, I just want to briefly talk about the intervention outcomes. So this was both the maternal and newborn outcomes. So looking at the maternal psychosocial outcomes, studies reported on knowledge, self-efficacy, behavior, stress, support, and attachment. And looking at what they found broadly, 89% were found to have a significant positive change after receiving the postnatal educational interventions when measured at the final time point. And then in terms of the infant outcomes, the outcomes that were reported, again, varied quite considerably across the studies. So studies reported on things like morbidity, mortality, exclusive breastfeeding rates, infant weight gain, kangaroo mother care, cord care, immunization, delayed bathing, and care seeking. And the outcome findings for this was a little bit more varied. So 56% reported a significant positive change at the last follow-up, but 35% reported no significant change. And so while the impact on newborn outcomes is unclear to variation in reporting, follow-up time points, and small sample sizes, when considering the effectiveness on parental outcomes, it's evident that outcomes were consistently better for parents who received the educational intervention than those who did not. However, there are challenges remaining in ensuring sufficient uptake and access for parents related to postnatal interventions. So given the evidence, it's important to really examine the strengths and limitations of the identified strategies. Given that parental targeted postnatal educational interventions require considerable resources, time, and involvement of healthcare providers. And so what's interesting is that in terms of the location, the interventions varied quite considerably. So 46% were provided on the postpartum ward, 30% in the NICU, 23% at home, 8% at a clinic or hospital, and about 12% through an e-health intervention. So next, I'm just going to share some analysis on these main intervention strategies and their strengths and limitations in terms of targeting parents for postnatal education. So the first one is in-hospital interventions. So the strengths of these is that with mothers who are in the hospital, you're guaranteed a presence in the hospital for at least a few hours. So there is an opportunity to reach moms kind of right away. And staff are available to provide education and answer questions who are already there, who are already on site and knowledgeable in the area. And it's also a key opportunity to provide the education to ensure mothers know when to return to care if needed. So you're able to provide information kind of right away. If something goes wrong, this is what to look out for, and this is when you should return to care. And it is cost effective because the nurses are already on site. And it can be multimodal, so you can provide it in many different ways, such as a pamphlet or modeling as needed. However, there are some limitations, of course. So there is a short length of stay. 83% of mothers leave within 24 hours. So there's not a lot of time to provide this education. Again, not all mothers give birth at hospitals. So if this is the only strategy that you're using, you will miss a lot of moms. It also places a higher burden on healthcare providers who are already overburdened and caring for a lot of patients. And on the parent side, parents are often overwhelmed, or mothers may be in pain and unable to take up information. So it may not be the best time to provide education. But despite these limitations, evidence from this review suggests that there is some benefit to providing at least a brief postnatal education to parents prior to discharge. which can be enhanced by providing content that could be taken home to review later or in combination with other strategies. Providing education during this period ensures that parents are provided with key knowledge that they can use when they're at home and to seek additional follow-up postnatal visits if they need it. So another postnatal strategy to reach parents is the use of postnatal visits. So this can occur by healthcare providers at home or at a clinic visit. So the strength of this is that it's flexible in terms of location. So it can be at home or it can be at clinic, depending on the country and the opportunities that exist. Again, it can be multimodal. So there's different ways that you can engage and provide the education. It can involve other family members, particularly if it's a home visit where fathers, other caregivers may be present, so that you can kind of teach everybody. And it's an opportunity to provide clinical care to moms and infants, as well as the education. So you're able to assess the moms and babies for any risks and direct them to further care if needed. There are some limitations, of course. So that, again, the low number of moms who return to postnatal follow-up clinics can result in missing some moms in terms of education. They may be unable to provide individualized education due to overburdened healthcare providers, particularly at a clinic. Postnatal follow-ups education may be provided in a group setting, which means it may not be individualized. There's also challenges on the flip side of implementing a home visit on a wide scale if the country doesn't already have it. So those are the pros and cons of the postnatal follow-up. And then looking at the e-health or mHealth or virtual, however you kind of want to phrase it. So it does offer a way to reach parents remotely through multimodal techniques. So the strength of this approach is that is very cost effective. It can be developed once and implemented and provided to a large number of people. It can be accessed remotely, which decreases the cost and travel time for parents and healthcare providers. Parents can access the information whenever they need it and whenever they have time or questions. It can also be developed to fit the local context, which is really important. So you can use the local language. It can be verbal or images, depending on what's most appropriate. So it can be quite flexible. And it can be reached a lot of parents on their own timing. The limitations for this, it does require mobile access, which not all people may have, particularly women in rural areas. And you're unable to provide a clinical assessment due to the in-person contact. Because everything is remote, you're not able to physically see the mom or the baby to make sure that they're physically okay. So due to the novelty of e-health interventions and the unique challenges in low and middle-income countries, it does offer a significant opportunity of reach, yet issues of access definitely need to be addressed in pursuing this stream. So several studies in this review utilized a combined approach, and while the ideal combination of educational strategies depend on the location, parents' needs, and feasibility, the findings from the scoping review suggest that combining multiple strategies for parent-targeted interventions may be the best to improve outcomes. So if you're able to combine in-hospital with a home visit and/or e-health, offers a potential solution in that it reduces the burden on healthcare providers at a single time point. And it ensures that parents are likely to receive at least some postnatal education intervention and care, depending on where they are and when they are there. And it also can include other family members, particularly if it's home visits or e-health interventions. So just briefly, in conclusion of this review, so parent-targeted interventions varied in terms of educational topics covered, the method and the location of the intervention, as well as the outcomes examined. And while the best strategy for implementing these postnatal education interventions isn't quite solved yet, there is evidence that suggests the current interventions do have a particularly positive impact on parent outcomes, but further work is really needed to evaluate the neonatal outcomes and to really identify the most effective method and timing of the interventions due to the significant variance that exists right now. And in terms of synthesis and moving forward, there's challenges related to measurement. So there's a lot of methods that were used, a lot of self-reported data, and a lack of standardized measures, which makes it hard to kind of synthesize the data in a more standard way. So based on the findings from this review, I became really interested in the possibility of using mHealth, providing parent-targeted postnatal educational interventions. So over the past decade, there's been significant growth in mHealth projects in low and middle income countries. And it's defined as the use of mobile phones to transmit various health content and services. And at the end of 2016, almost 5 billion people had a mobile phone, making it a technology that is really integral to most people's lives. So this led me into a systematic review looking specifically at mobile health interventions during the perinatal period, targeting moms in low and middle income countries. So the objective for this review was to really look at neonatal outcomes in conjunction with maternal behavior change outcomes. So there's been a lot of reviews conducted on mHealth interventions, but this is the gap that we found that we felt needed to be answered. So the questions are, what is the impact of mother-targeted mHealth educational interventions on maternal knowledge, self-efficacy, and antenatal and postnatal clinic attendance in low and middle income countries? And then looking specifically at neonatal mortality and morbidity outcomes as well. So our focus was a little bit tighter for this review. So we, again, based on the findings that most interventions just focused on mothers, we decided just to target mothers in low and middle income countries. The intervention had to be an mHealth education that was provided during the perinatal periods. We broadened it a little bit, so from conception, so anytime from pregnancy up to 42 days postpartum. Again, we included any comparison group. And we included all experimental and quasi-experimental studies that were published in English after 2000. So the outcomes that we were interested in for this review, as I mentioned earlier, were knowledge, and we included this measured kind of however the studies reported it, self-efficacy, attendance at postnatal clinic contacts or postnatal clinic contacts, first day neonatal mortality, and then neonatal mortality within 7 days and 28 days post-birth, and then any morbidity. And as this search was a little bit tighter, we had significantly fewer studies than the last one, with just over 1,500, and we ended up including 20 in the final analysis. Briefly, looking at the studies, 45% of the studies here focused just on the neonatal period. So that means they provided the mHealth interventions only while women were pregnant. 40% spanned the antenatal and postnatal period, and only 15% targeted just the postnatal period. 11 of the studies were quasi-experimental and 9 were randomized controlled trials, and the sample sizes ranged from 12 to over 3,800. And most studies were conducted in upper middle income countries, followed by lower middle income countries and low income countries. And it was interventions were provided in 14 different countries in total. So the studies varied significantly in what they were focusing on, similar to the last review. So there were 5 studies that primarily used text messages as a reminder for perinatal appointments. Others were used to evaluate mHealth as a complement to existing perinatal care or as part of a larger program. Some studies focus specifically on HIV positive mothers to increase their postnatal care and testing. Some focus just on breastfeeding, as well as increasing care seeking or knowledge. And the mHealth interventions varied in terms of the frequency of messages, varying from only 1 up to 148. And some included unidirectional and bidirectional. And most studies use text messages, with 3 of the studies using voice calls. So looking briefly at the results in terms of the outcomes, due to variation in reporting, we weren't able to do kind of the more quantitative analysis for all the outcomes, but we were able to look at it kind of narratively. So for knowledge, this was reported in 5 different studies. and 2 studies had mixed effects and 3 found no effects between the intervention and control groups. So those who received the mHealth intervention and those who didn't. 3 studies reported on self-efficacy. Again, due to differences in reporting, we weren't able to do any kind of quantitative analysis, but we found that 2 studies had a positive effect and 1 found mixed. So this one was a slightly better outcome. And so this is a forest plot. So this is one of the few outcomes that we were able to kind of synthesize the information in a standardized way. So attendance at postnatal clinics was reported in 8 studies, but reporting varied among the studies. So we were able to include in this meta-analysis 6 studies. And these are all the studies that we included. And what we included was the intervention. So that means they received the mHealth education, and the standard care means they didn't. And this is the average number of antenatal visits that they had. And so this program calculates the likelihood overall. So we found that women who receive an mHealth intervention were significantly more likely to attend an antenatal care contact, or to attend more antenatal care contacts than those who received standard care. And then the 2 studies we weren't able to include in here also, 1 found a positive effect and 1 found no difference. And then similarly with attendance at postnatal care clinics, this was reported in 6 studies, but we were able to look at 3 studies that reported in a similar way. And so slightly different than antenatal, which was the number of antenatal visits. This was the likelihood of attending at least 1 postnatal clinic contact. And what we found is that there was a positive impact from receiving the mHealth intervention for women to receive at least 1 postnatal contact compared to those who just received standard care. And the other 3 studies also found that trend, that they found a significant improvement in postnatal contacts for the mHealth education group versus those who did not receive it. Shifting into the neonatal outcomes. So in terms of mortality, this is not reported as frequently. So only 1 study reported on first day mortality, which found no significant difference. 1 study reported on early mortality at 7 days, which found a positive impact for the mHealth intervention, but this disappeared at early neonatal mortality up to the 42 days, which found no significant difference. And then morbidity, there were 2 studies that reported on morbidity. So 1 found a decrease in the likelihood of infants experiencing an acute episode requiring a clinic contact for the mHealth intervention. And then the other one found a lower likelihood of acute respiratory illness and diarrhea, but not for fever at 6 months for the mHealth intervention. So what we can see is the one more consistently reported outcomes was antenatal and postnatal clinic attendance, of which mHealth interventions was found to improve the average number of antenatal clinics and having at least 1 postnatal clinic contact. So there's strong evidence for the improvement of postnatal and antenatal clinic contacts for mothers who receive an mHealth intervention. However, maternal outcomes related to knowledge and self-efficacy remain mixed. There's a lack of standardized measurement tools on these, which limits the ability to accurately synthesize the impact of mHealth interventions. And there's also a dearth of information and reporting on neonatal outcomes, with only 5 studies reporting on these outcomes, suggesting that there's insufficient evidence and limited conclusions that can be drawn on the neonatal outcomes. And then due to differences in timings, frequency, and purpose of mHealth interventions, there were challenges in really generalizing and evaluating key maternal and neonatal outcomes. So I'm going to bring this all together and then open up the floor for questions. So there's really been a growth in parent-targeted postnatal educational interventions since 2014, which mostly positive impacts on maternal psychosocial outcomes, but mixed impacts on neonatal health outcomes. And I'm suggesting that future work is really needed to identify the best content focus, the educational approach, and the frequency of interactions, as right now it is quite varied and different depending on who's developing the intervention. And then when I look specifically at the health interventions, you can again see that there's the impact on psychosocial outcomes and neonatal outcomes remains quite understudied and mixed, but there does seem to be positively impacts on antenatal and postnatal contacts. So health interventions should include information, reminders for perinatal appointments for maximum impact. So I'd just like to acknowledge the co-authors and my funders for all of this work, and I'm happy to take any questions at this time.
Awesome. Thanks so much, Justine. That was really great and informative. If people have questions, you're more than welcome to come off mute. I think we have like a good sized group here. But if you're more comfortable, feel free to also put your questions into the chat and we can voice them too.
Hey, hi, Justin. This is Seema.
Hi.
So nice to have you, because we found your scoping review, the first one especially, very, very interesting. We've referenced it as well and intend to use it very extensively. And it's nice to hear from you directly. I had a few questions. Okay.
Sure.
Where is it? Okay. You didn't have any RCTs in the first study, right?
We did.
You did?
Yeah.
Okay.
Yeah.
Okay.
I think there were 42 RCTs in the first study. I'm just trying to pull up the, 42% were randomized controlled trials.
Okay.
Yeah.
So some of them had multiple interventions, right? And when you say 56% reported improved outcomes, was it, did you count it as any one outcome that improved, or was it like all the outcomes?
So it would have been like if they reported on self-efficacy and it was positive, that would have been 1. If they reported on knowledge and that was positive, it would have been 1. So like looking at all the interventions, how many were positive, or like outcomes, how many were positive?
Okay.
Yeah.
We don't have a sense of by what percentage it changed. It's just that whether it was positive or not. Okay.
Yes. Yeah.
In the initial slide, you talked about the decrease in mortality the range of decrease in mortality that can occur because of parent-centered education.
Say that again.
The decrease in mortality?
Yes, mortality.
And that was out of the scoping review or out of general literature?
So mortality.
Yeah, almost.
Yeah, so mortality was one of the outcomes that we included in the intervention, but I would have to go back to the original data to like see how much, like how many reported on mortality and how many of that would be positive. Like we just grouped it as a whole, looking at neonatal outcomes.
Sure, okay. You talked about parent outcomes versus newborn outcomes. Can you expand on that?
Yeah, so parent outcomes would be things that we, for the scoping review, looked like was a measurement of a parent, how a parent was feeling. So like knowledge, self-efficacy, were they attached? Whereas the infant outcomes would be like things that specifically are related to the newborn's health. So mortality, whether you did breastfeeding, kangaroo mother care, so things related to the baby. So the parent outcomes were related to more psychosocial outcomes. How are they feeling? That type of outcomes versus health outcomes.
So breastfeeding typically fell into neonatal outcomes rather than
infant outcomes. Yeah.
Okay. I have more questions. Please let other people ask. I'll think about the other questions.
Sure.
Anyone else have a question that they'd like to come off mute for and ask? If not, Seema, if you have more, feel free to take the floor back.
The number of interactions versus outcome. Did you do a subgroup analysis saying as the number of interactions increased, did the outcomes also increase? Positive outcomes?
So that would definitely be an interesting question, but the way that the scoping review is designed, it's more like a broad picture rather than like subgroup analysis, but that is definitely something that could be done. The only thing that I could foresee being an issue is that there's so many that just had one interaction. And then after that, it kind of varied quite considerably by the number of interactions. So it would be hard to really have groups big enough to like, it may not, the studies that may be included, for example, there's only like 9% that had 2 follow-ups, but so they may not report on all the outcomes. So it would be hard to kind of tease apart.
Yeah. So after 2017, I know you've not done a formal review, but being in that field and you will be looking at new evidence, is there a synthesis that you've kind of built into, or are you planning to publish more?
I think it would be really interesting because as like I showed from 2014 to 2017, there was growing. So since then, like it's been 5 years now, I'm sure there's even a larger percentage of studies. So I think it would be really interesting to do that. I'm happy to partner with you guys if you're interested in doing that. But I don't have any time at this, like plans at this time to update it.
That may be a very interesting thing to partner on. We can it'll be a lot of learning for us because it's our core area of intervention too, as you see. And yes, and it'll be good to have your guidance because you've already been publishing scoping reviews and things like that.
Yeah.
Another question I have is, when you look at these studies and you want to have studies with numbers reported in the right way, with tools being used in the right way so that you can do the meta-analysis, and I'm sure you would have felt disappointed saying, I wish the study had reported this in more detail.
Yeah.
Right? Whether it's the study design or anything that helps you do the meta-analysis better.
Yeah.
Maybe a critical part is missing. And what I'm thinking right now is how do we ensure right from planning stage, or if not at the planning stage, we are on various studies in the maternal health education space. We are at various stages in our study designs. Some are already up and running, some are open for in the initial stages of planning, some are would it be possible for you to advise whether on the protocol itself or the questionnaire saying, if you include this particular question, it'll make it that much more easier for somebody else doing a meta-analysis?
Yeah, I think that's definitely one of the biggest challenges. And like, because the literature is quite diverse right now, there's no real like, you should do this, this, and this. But what I think, what we can see from the work is that a lot of the studies report at measurement times at discharge, 2 months and 6 months. So it makes sense to have these kind of standardized time points in terms of, so you could collapse by other studies in terms of that. The other thing that I would recommend is using standardized measures, or if you don't have a standardized measure, like there isn't one on like newborn knowledge, right? Like that doesn't exist. But like, if you can't do that, at least provide the questionnaire as supplementary material, right? When you publish, so that someone can look at it and see how it's similar or different. But if there is standardized measures, like if you're doing self-efficacy, like use a standardized scale. And like part of the challenge is like the language, right? Like a lot of the scales are developed in English and not necessarily valid in a different language. So it adds another step there. But for things like neonatal outcomes, like these are reported in standard ways, like first day, like early and late, right? Like collecting those data and reporting it specifically, like as specific as you can, rather than like grouping.
These are very, very useful tips. Thank you. And if time permits, if are interested in growing the partnership, if you could, to the extent possible, I mean, I don't want to be imposing just because we've called you for a research speaker series, we shouldn't be too imposing, but we'll be happy to share our tools for a very quick review or feedback.
Yeah, for sure. I'd be happy to. Yeah.
Really nice. Regarding standardized questionnaires for efficacy, did you find anything that is like short? See, I can explain our method of data collection. Typically, we collect the phone numbers in the hospital, some demographic details in the hospital, and we call them 30 days later because that is covering the neonatal period, just
Yes.
once over the phone, and collect self-reported measures. So the phone questionnaire itself is fairly short, and repeated follow-up calls is fairly challenging.
Right.
But in this, so trying to keep for every question that we add on to the survey, we are trying to really weigh in and see whether it really needs to be there or not. But still, it'll be very good to have at least to look at standard efficacy, self-efficacy standardized questionnaires if you have any.
Yeah, so the one I use is quite short. It's only 15 questions on like a Likert scale, so it wouldn't take too long. I'm happy to share like what I use. Like there's like the manual and like the original paper, so you could see whether it would be applicable in your setting. And I think like I totally understand you want it to be as short as possible. So I think using something like that could be, and it's like a scale that is like from birth to 12 months. So it is quite, it can be used for moms and dads. So it is quite user friendly.
Thank you. And in the mHealth interventions, was there WhatsApp only interventions that you looked at, or was it a variety?
Mostly text messaging and then a few voice calls. I just can't remember. I don't think there was WhatsApp from what I recall. But I know that that's what you guys use. So I think it would be like good to like, and like, I think WhatsApp has grown since the study. Cause again, that search was from 2017, 2018. So again, since then, there's probably been a large growth in WhatsApp interventions, because it's not only does the social media platform have to be there, it has to be used long enough in a research study to like produce the output. So I'm sure if we did an update, there would be more apps or WhatsApp interventions that are being used, particularly in low and middle income countries.
Thank you. I'll let others discuss.
Anyone else have any questions?
Shirley, your questions?
I was gonna wait to give the floor, but yeah, I do have one question. So we, the MCH space is one of many that we look at. We also look at oncology, cardiology, inpatient tuberculosis, and COVID as well. And so I'm curious, I know a lot of your expertise is in the MCH space, but I'm curious if, if you've been sort of pulled in thinking and applying like either the mHealth piece or the like, not parent focused, but family focused patient education class into other condition areas or directions. And if so, if you sort of learned anything from there.
Yeah, a little bit, not a whole lot. I think there are definitely a lot of probably reviews out there that you could find. I know I also work in a pediatric pain lab, and so I wasn't involved in this review, but a colleague was working on it, looking at mobile apps for like pain and like the impact of and looking at patient kind of outcomes. So it might be similar to like cancer, and like, so it's directed to like evaluation of pain apps. So it could be something similar to that. But what they found was that a lot of the apps were developed, but not actually like available to people. They were just part of a research study. So they weren't actually available for download on apps, on the App Store or Google Play or whatever. So that's definitely like a limitation of mHealth for specific areas, is like it's developed for research, but not available to actually use.
Totally. Okay, thanks. That's helpful. Yeah, I could, for us, like the thing that's a bit interesting, but also tricky about the MCH space is that health of it is very specific, and it's also quite big versus some of these other more chronic and ongoing health diseases like oncology, for example, where someone's hospital visit is one out of many that they'll have. But
right.
Thanks.
Yeah, and I think you could develop like mHealth interventions for chronic issues like cancer. Like you have all the literature like about like and you could subdivide it by type of cancer, age of the patient. Like you could have specific recommendations and even just information for patients because they may not be aware. So I think you could apply an mHealth approach to any like health concern.
Thanks. That was my big question. Anyone else have any final question? Seema, maybe.
One more. Quasi-experimental studies I've seen both kind of the pre-post, the standard pre-post before a launch of a program, after a launch also being described as quasi-experimental. In several literature, they describe it as a pre-post and reserve the quasi-experimental where you do for a different set of study design. So I just wanted to understand that we've been using quasi-experimental for our pre-post study design. What does the larger academic circle agree on?
I think we could you can use they're kind of grouped together in terms of like quasi-experimental. So if you were doing a specific review looking at like randomized controlled trials, like a Cochrane review, like any quasi-experimental studies would not be included. But I use the Joanna Briggs Institute approach, which is a more inclusive way of looking at it. So it really varies. Like the quasi-experimental with the control group, 28% of the studies in the original review use that method. So you would be able to compare to other quasi-experimental studies, but not necessarily pre-post. So one thing that you could do is like collect a pre in your like intervention group and like with your control group. Do the pre-post. You could kind of have both together. Like you would be able to compare, was there a change within the intervention group? And then was there a difference between the intervention and control group? So it would just be like one extra set of questions kind of at the beginning, if it was a lot like in your study design feasible. But I don't think that there's like a strong preference for either one. It's really depending on what the design allows if you're going to do a quasi-experimental.
Sure. On that note, when you said pre-post, does it mean the same person is getting this questionnaire before the intervention?
Exactly.
Okay.
Yeah. So you would collect it.
Pre-post. Yeah.
Yeah. And then the comparison would be after.
Cool. Okay. Well, what we'll do for folks at NORA, we'll circulate Justine's contact information. So that's okay, Justine, for us to do that.
Yeah,
and
for sure.
Folks have other questions, like you're more than welcome to reach out to her. But yeah, thanks so much for the session today. I know I learned a lot, and I think Seema too, and I hope everyone else as well. So yeah, thank you so much for your time, and we really appreciate it.